ABG interpretation, case study, Aglan protocol. How to study ABG? 4 items. Number 1, listen carefully to the clinical history. Number 2, study the lab investigations, including the ABG chart. Number 3, look at this Aglan ABG table to fill in the spaces measured and calculated. Number 4, back to this Aglan ABG table to study pH, chloride items, bicarbonate items, oxygenation state of the lung, and ventilation state of the lung. Clinical history. Study of the clinical history will be important for 2 things. Number 1, to anticipate the pathophysiology. Number 2, to anticipate the sequelae of events. Anticipation of the pathophysiology, like what? If the patient is vomiting, he's going to lose chloride, gain bicarbonate, to develop hypochloremic metabolic alkalosis. If the patient develops diarrhea, he will lose bicarbonate, gain chloride, to develop hyperchloremic metabolic acidosis. If the patient develops diabetic ketoacidosis, bicarbonate will be consumed, so he will develop high anion gap metabolic acidosis. In a renal failure patient, bicarbonate will be consumed by the fixed acids to develop also high anion gap metabolic acidosis. Methyl intoxication will be associated with the formation of formic acid to consume bicarbonate to develop high anion gap metabolic acidosis. Stable congestive heart failure, the patient will have hyponatremia, maybe on diuretics like furosemide to develop hypokalemic metabolic alkalosis. Liver cirrhosis patient will have hyponatremia, hypoalbuminemia, hypokalemia, and develop metabolic alkalosis. Anticipation of the sequelae of events, like what? If the patient develops vomiting, then became shocked, vomiting will develop hypochloremic metabolic alkalosis, then shock will develop high anion gap metabolic acidosis. Lab investigations, you should study sodium, chloride, potassium, BUN, serum creatinine, random blood sugar, ketone bodies, and serum lactate. Then come to the ABG chart to study it, to see the values. For the calculations of the calculated items, don't forget these formulas, these equations. I collected it in the form of golden rule in these 4 slides. You should know it by heart. Number 3, look at the Aglan table and fill the spaces. These spaces are 2. Number 1, the measured items will be taken from the lab investigation and the ABG chart. Then the calculated items with these red arrows, you have to calculate it before starting the Aglan ABG table. Number 4, study Aglan table. This Aglan table, as I have mentioned before, is formed of measured values and calculated values. To start with, number 1, by the pH. Number 2, the chloride items. Chloride items, serum chloride, chloride sodium ratio, corrected bicarbonate, and strong ion difference. Number 3, bicarbonate items, serum bicarbonate, anion gap, buffer base, strong ion gap, base excess. Number 4, oxygenation state of the lung, FiO2, BO2, B arterial oxygen, partial pressure of oxygen of arterial oxygen, and alveolar arterial gradient. Number 5, ventilation state, the partial pressure of carbon dioxide and its relation to the pH and bicarbonate. To study the pH, for sure, see whether is it normal, acidemia, or alkalemia. Start studying the chloride atoms. Number 2, as I've mentioned before, serum chloride, chloride sodium ratio, anion gap, strong ion differences, and corrected bicarbonate. From these items and from these data, you will come to the diagnosis of the start diagnosis, start pathology, the first pathology. Number 3, studying bicarbonate items, serum bicarbonate, buffer base, phase excess, strong ion gap, and anion gap. This will give you the last or the second pathology and the second diagnosis. Number 4, the oxygenation state of the lung will be studied through studying FiO2 and BaO2, and you will come to the formula alveolar arterial gradient to diagnose the oxygenation state. Is it normal or hypoxic? Number 5, studying the ventilation state through studying the partial pressure of carbon dioxide correlated with bicarbonate and pH. See whether the patient is hypoventilated, hyperventilated, normoventilated, compensated, or not. Case number 2. A 20-year-old diabetic man has been vomiting for several days. He appears ill and dehydrated. So I expect 2 pathology. Number 1, vomiting. Number 2, hyperperfusion. When it comes to the lab investigations, pH is normal, 7.4. Partial pressure of carbon dioxide is normal, 40. Partial pressure of oxygen is 100 normal. Bicarbonate 23 normal. All the Abg normal. Sodium is 140 low, potassium 3 low, chloride 75 low, and random blood sugar is 500 milligram per. Let's come and study the Aglan table. The first thing to study is the pH. pH here is normal, carbon dioxide is normal, and bicarbonate is normal. Then what happened? Come to the second item, which is chloride items. Number 1, chloride, serum chloride is 75, slow. Serum chloride to sodium is 53%, slow. Normal is 74. This means that there is a loss of chloride due to vomiting, hypochloremia. When it comes to the strong ion differences, more than 40. So this is hypochloremic metabolic alkalosis. What about the corrected bicarbonate? Corrected bicarbonate is 53. So this patient, from vomiting, he developed hypochloremic metabolic alkalosis. Then most probably he developed the ketoacidosis. Why? Bicarbonate dropped from 53 to 23 to the normal, but there is a drop of this bicarbonate. That's why when you come to the buffer base, return to normal. Base excess or deficit, no, it's 0. It's normal bicarbonate. But what about the strong ion gap? Strong ion gap is very high, 32. Normal should be 0. So this patient developed, after the hypochloremic metabolic alkalosis, developed what? High anion gap, 42, metabolic acidosis, drop of the bicarbonate from 53 to this value 23. So this patient developed a high anion gap metabolic acidosis. That's why the picture came, as you see, it's normal. When it comes to the oxygenation state, he was in room air. The calculated alveolar pressure of oxygen was 102. The measured arterial oxygen was 100. Alveolar arterial gradient was 2. This is normal. So there is no problem for the oxygenation state of the lung. When you come to the partial pressure of carbon dioxide is normal, the ventilatory state is normal. So this patient had hypochloremic metabolic alkalosis due to vomiting, and then developed to be followed by high anion gap metabolic acidosis. Thank you.